Okay, good morning. Thank you all for coming. So I have to introduce myself as Rebecca wouldn't introduce me. Sorry, just a joke between us. So what we're going to talk about this morning is radiation treatment. When? Yeah, that's right. Yeah, visiting Professor Murray like yourself. What we're going to talk about is radiation treatment utilization. And that's one of the things, actually, as Michelle will say at the very end, is something, it's a term that we don't really like as a thing because it implies treatment unit utilization rather than the fact of what it really means is ensuring that patients who would benefit from radiation therapy actually receive it. So there's three of us going to present this morning, Michelle, Michael and myself. So I'll start off. And this is the radiation treatment program vision at Cancer Care Ontario. It was the one developed by my predecessor, Tony Whitten. I saw no reason to change it. We want timely and coordinated treatment as safe, evidence-based and technologically innovative. These are our program goals. And we want to appropriate and quality radiation treatment based on best evidence. Safety is a big issue. The big one we're going to really talk about this morning is about ensuring that all patients access the radiation system appropriately. We want coordinated care and in a setting of technical innovation, participation in clinical trials. And you will hear more about this over the next little while, but you may have seen something on it over the last week or two. Ontario Cancer Plan 4 has just been launched. And on the back of the previous Ontario cancer plans, and I think it's important to note that in the previous three cancer plans, anything that was actually mentioned in there or actually stated in there was generally being funded by the Ontario government. This is the theme of this one is Together We Will, and again, working together to get the best health system in the world. I'm not going to talk much about it, but these are the six sort of themes of it. The quality of life and patient experience, safety, and the one again for today really is talking about equity, ensuring that the health equity for all Ontarians across the cancer system, as well as integrated care, sustainability and effectiveness. And there are other aspects to the radiation treatment program. We try to map where the radiation treatment program comes in here, and again, under the equity button is improving radiation treatment utilization. Other ones, I mean, the integrated care, we're currently working with some of you in the room on concurrent radiation and chemotherapy. There's a big initiative around that area, which is an area that most of us across the province think is done very poorly for patients. So, I'm going to just talk about utilization. The proportion of patients who receive radiotherapy, and we've tried to move this to within the first year of diagnosis of a new cancer. These one-year rates differ from the previous definitions that you would have heard of lifetime utilization, but they predict, the one-year rate predicts very well what the lifetime utilization is. And it also, we feel the one-year rates are sensitive to change. And we're going to talk more about the benchmarking methods when Michael comes up, but they're really, the target rates are based on benchmarking methods, patients diagnosed in a hospital with radiation on site, and then standardized for age and primary site distribution. And the Ontario benchmark rate, and as Michael will tell us how that was developed, is 33.6% in 1 year. So the problem is that provincial utilization rates fall short of target rates. The 1 year, as I said, is 33.6. The actual is 29.9, the shortfall about 11%. And in absolute terms, this shortfall we have estimated is about 2,500 new diagnosed patients annually. And it is observed across all major cancer sites, though, you know, it is nice to see, I think, that rectal cancer actually does approach it in certain ways, but in certainly other sites, there's a significant shortfall. And it varies substantially between LINs. And as Michael has explained to me, that when there's a difference between LINs, this difference needs to be explained. This variability needs to be explained. It doesn't necessarily mean that there's something wrong, but this variability does need to be explained. And this variability is between in Lin 7 is where we are. It differs for different cancers as well, lung cancer and breast cancer, just to hear them as an example. And it also varies by county. If you look at it across the whole province, there are variabilities on one-year utilization rates by county. But this isn't a new problem. This is nearly 20 years ago, and this is, as many of you will recognize, Bill McKillop. And what I've done here is to shorten the abstract from a presentation, a paper of his. And I'm sorry Bernie isn't here, because Bernie was also on the paper as a major author. And this was to see if this highly centralized radiotherapy system provides adequate and equitable access. And they identified nearly 300,000 cases, 84 to 91, and linked them to see whether they actually got radiation. And the proportion of incident cases treated with radiotherapy is 29.1% at 8 years. Interestingly, when we now look at that in an approximation of that figure, which is our current lifetime utilization, we're actually up at about 38.5%. So we've made significant change over this time period. We have had major improvement, but we're still trying to address the 2,500 patients that did not receive treatment who would have benefited from it. So what the low and uneven rates of radiotherapy use across the province indicate that our centralized rate does not provide adequate access to care. But I point out that this paper was in 1997. And, we're now in 2015 and have not fully addressed the issue. So that is just an opener. So Michael, if you want to take over.
So thank you, Padraig, and thank you for the invitation to come. So those of you who don't know me, I work at Queen's in Kingston. I'm the director of the Division of Cancer Care and Epidemiology there, which is part of the Queen's Cancer Research Institute. So I work part-time as a clinician. I spend some time with Dr. Milosevic thinking about quality of care, but mostly what I do is epidemiology and looking at patterns of care and quality of life outcomes. So I'm going to put on my epidemiologist's hat and talk about access to care and utilization, as Padraig explained it. Padraig's actually given you the bottom line already, so those of you that want to go have coffee, the rest is detail, but I hope you'll enjoy the detail. You'll understand hopefully better how we got to where we're going, or how we got to where we are, and understand where we're going. So this was in the paper just yesterday. This figure, or one like it, was in the Globe and Mail. This was on the news. The Canadian Cancer Society has rung the alarm bell saying we're all in trouble. The amount of care that we're going to have to provide in the next 20 years is almost staggering. And this graph projects cancer incidence. So the top line here is total cancer incidence, more and more patients in absolute terms. These are thousands of patients on this axis. Why is that going up steadily? It's because of two key reasons. One is the population is growing. That's this difference here. We're having more and more people join us in Canada, either through immigration or through new families. And we're all getting older. That's the biggest problem. The shift of average age keeps going up. And since cancer happens in older people, there's more and more cancer as we all get on average older, and there's more of us. So staggering numbers of cancers to deal with. This is a framework from our textbook chapter. This is from Gunderson, if anybody wants to go look at it in more detail. But these are the ways we think about those cancer patients having access to care. So we got more and more cancer patients. How are we going to provide access? We have to think about availability in terms of our total system capacity. We have to think about spatial access. So even if the machines are available, are they close enough for patients to get to? In the same vein, but different than distance, we have to think about how long we operate our machines to get people in, transportation services, hospitals. Is it affordable? And the bottom one, are physicians aware? Are people referring appropriately to radiotherapy? So these are the major dimensions that we have to think about when we think about what determines whether patients get radiotherapy or not. And most of what you can think about would be a roadblock you can put into everything that is a roadblock you should be able to put into one of these categories. So utilization, why are we interested in it? We can measure the demand side. We can calculate how much radiotherapy we ought to give. What's the demand based on these epidemiological principles? And if we can figure out how much we ought to give, we can compare that to what we're giving and measure the shortfall, just as Padraig has outlined for you. So the top line here is the same line I showed you just a few minutes ago. That's incident cancer cases. These are counts. So this just keeps going up and up and up. And the bottom line is how much treatment we give. So these are cancer cases treated with radiotherapy within a year of diagnosis. And you can see that we treat more and more patients in Ontario every year. It's no wonder we're all getting a little bit tired. There just keep coming more of them. And we have to figure out how to deal with it. But what's the relation between that line and this line? What proportion of these patients actually get radiotherapy? So here's the estimated lifetime use. And you can see Dr. McKillop's paper was in 1997, as Padraig points out. That paper analyzed this kind of time frame here, 86 to 96. You can see that the lifetime utilization was 29%, as published in that paper, around 30%. But as Padraig mentioned, we have made lots of progress. We're treating more and more patients over the years, a higher proportion of incident cases, and now we're pushing 40% as the lifetime utilization. So we're doing better. You can see that this curve has had fits and starts as based on all of the things we were doing in the province in 1990, sending patients outside of province, etc. So it's no wonder it's not just a straight normal relationship. The problem with that curve is it takes a long time to measure it. These patients are easy because you can follow them for 20 years. But the patients treated recently, we don't know what their lifetime utilization is. We can only estimate it. And we estimate it using the same techniques that life insurance companies use to estimate our life expectancies and decide whether we're insurance risks or not. You can model basically what's going to happen to 100 people based on what you know about them and based on the 1-year utilization rates. So instead of actually following people for 10 years, we follow them for 1 year, measure the rate of radiotherapy for 1 year and use that to estimate lifetime risks. Or we can forget about lifetime risk, it's just an estimate. Let's actually use 1 year utilization as a useful indicator for how accessible radiotherapy is. So that's what we do now. We just measure it for a year. We can report back to programs. Here's what happened last year, at least in theory. And you can change your approach to accessibility and hopefully see a change in your 1 year utilization rates. The curve is going up for all major cancers. Breast cancer, prostate is at the bottom here, and rectal cancer. Prostate's the flattest of the bunch, as you might imagine. And as Padraig said, it varies a lot by county. So the black counties here, these are 1 year utilization rates. Our target is about a third, 33%. So these black counties pretty much meet that target. As it gets lighter and lighter, the counties have a bigger and bigger shortfall from that target. So how do we know that? How do we know that 33% is approximately where the sweet spot is in terms of 1 year radiotherapy? Well, the bottom line is we don't know, but we think we're pretty close, and I hope to convince you of that. So we can just ask people, and for years the CCO benchmark was set on just consensus of where it probably should be. And then people started using evidence-based approaches, and Bill led the charge to do benchmarking approaches. So let's talk about evidence-based approaches. This is a technique where you basically do a decision analysis or a very big decision tree. So you take a population like lung cancer. First thing you do is divide it into small cell and non-small cell. The next thing you do is look at all the indications why a small cell case might get early radiotherapy, limited disease, for example, or all the possible reasons why a small cell case would get late radiotherapy. So you work your way through all major diseases, all subtypes, all major indications for radiotherapy. You piece all that together, and then you try to integrate that information. So here's what the lung cancer one looks like. This is overall. So this is some cases are diagnosed post-mortem. Obviously, they're not going to get radiotherapy. Most diagnosed pre-mortem, small cell, non-small cell, early and late. And Each of these decision tree arms has a lot of detail hiding underneath of it, but you can basically add all these things together, estimate the probabilities of following any one particular branch, estimate the indications for radiotherapy within that branch, and you can add them all up. And if you do that, your decision tree says approximately 44% of lung cancer patients should get early radiotherapy, and another 16% should get late radiotherapy. So that's a mathematical approach to the problem based on everything you know about lung cancer. The other way is to do benchmarking. Benchmarking is basically inductive. You just see what happens, and you take that as the gold standard. This is a business approach typically, where your best performers are your benchmark companies. We're not in a business environment, but we can identify communities in which we think the rate of radiotherapy access is most likely to be optimal. So the game here is to pick communities that fit our criteria of optimal or likely optimal access to care. We measure the rates of those communities and we say, okay, those are the best performers. That's our benchmark utilization rate. It's a much simpler way to just see what happens and take your best. We think access is optimal when there's no barriers, when the decisions are made by experts and there's no incentives. Pretty straightforward approach. So remember I showed you those gray and black counties. These are the same counties now ranked by utilization. So these are the counties where the utilization is lowest. These would have been the light ones on that graph. These are the black ones over here. And you can see there's the ever-increasing trend of utilization if you order them by utilization. And these are your best performers. And it just so happens that they all happen to have cancer centers in them. So counties that have cancer centers perform better than counties that don't have cancer centers. And if you take your benchmarks, you can estimate the rate, this is for lung cancer, at 44% and the shortfall at 10%. So it turns out that the benchmark approach here very closely approximates the evidence-based approach, both around the low 40s in terms of where we ought to be for lung cancer. So in this case, we're happy because the methods converge and we're pretty confident that about at least 40% of lung cancer patients ought to be referred for radiotherapy. It's concerning that the actual rate is 10% lower than that. So here's what the numbers look like for lung cancer. According to our current standards, the benchmark rate is 41%. The evidence-based rate from Canadian estimates is very similar, and the observed provincial rate is much lower. So it's pretty convincing by that we've got an issue in lung cancer access to radiotherapy. The nice thing about the modeling, the evidence-based requirements, is it's transparent. Somebody can replicate it. They can check all your probabilities. They can check all your indications. They can argue about the details. It's flexible because you can change arms. You can change probabilities. You can recalculate your curve. So it's attractive to people who like numbers in that way. But it is deductive. So it's a garbage in, garbage out program if your data are fallible. It requires a comprehensive list of indicators. So it's very difficult to use for rarer cancers. It requires a detailed information of case mix. So you need to know where each patient falls in that possible matrix of indications that you want to look at. And that information about case mix is usually unavailable at the provincial level. We have it sometimes within institutions, but it's difficult to project at the provincial level. And patients' preferences and how they impact that decision tree are often unknown. So it's complex and it's time-consuming, but it does provide an estimate, although that estimate has the potential to be either too high or too low. The nice thing about benchmarking is it's inductive. It's based on grounded observations. You can do it for any type of cancer if you have enough numbers. It's inexpensive, and it's unlikely to generate overestimates. It's unlikely that there are major areas of the province where we overutilize radiotherapy. That's a belief rather than a proven fact, but I think it'd be very hard to argue that in large areas like counties or census tracts, there'd be systematic overutilization of radiotherapy. So if anything, it's dangerous to underestimate. The weakness of criterion-based benchmarking is it makes the assumption that optimum is indeed optimum, that your best performers are the best, are maxed out, and that there's no further improvement to happen after those. So it does make the assumption that at least in some parts of the province we are meeting expectations. So we just published this paper in the Red Journal. This is kind of Bill's swan song on this issue. Bill has led these efforts over the years. So the slides that I've just shown you are really all his work. I'm the KT guy, so I get to tell you about it. But he's done a lot of thinking about this. So I'm just going to spend a moment making a couple of comparisons. So the Australians have done a lot of work with that modeling technique, the estimated demand for radiotherapy. The people in England, read by Dr. Round and colleagues, have done a mixture of evidence-based with benchmarking. In Canada, Scott Tilsley and before him, Lisa Barbera, did a lot of work with evidence-based approaches. So we have the Australian approach, the UK approach, the Canadian approach, and we have some benchmarking. So let's just look at how all those, so this table is from that paper. It's condensed a bit, but here's the bottom line. So let's look and see how things work out here. If you look at breast cancer, let's focus on this first column. The actual rate in Ontario is about 70% of patients. The benchmark estimate of where we ought to be is 74%. The Canadian estimate, based on all of our modeling, is 66%. And the Australians' estimate, based on all of their modeling, is 87%. So something's wrong. These are either really bad diagnostic tests or the methods are flawed. But something is happening so that the benchmark, the eBest and the AEBest, come up with different answers about the right rate. So now we're skeptical, right? Okay, you guys can't agree, the methods don't agree. I'm not buying any of this because it's not replicable. If you do drill down, you start to find reasons why these differences exist, and you start to worry less about the lack of concordance. But the issue is that the answer about which rate is the right rate depends on the methods you use to estimate it and who's using those methods. You get different answers using the same method depending on whether it's in the southern or northern hemisphere. So that's our challenge. So we've argued that there is still room for improvement. We're not where we want to be. Let's keep it simple. Let's, instead of modeling all of this, let's just use observed best performers as the benchmark and compare the rest of the province to the areas where radiotherapy seems to be appropriately and optimally utilized. It's really just that simple. So you can understand that there's lots of debate about the details of what's the right rate, but I'm pretty confident that we have decent rates, and I'm gonna show you why. So the next thing we did with this project is, instead of looking at counties, we looked at hospitals, because referrals come from hospitals, they don't come from a generic county. And we thought this was a better way of implementing change, so finding interventions that would target hospitals rather than just target generic LINs. So we set about trying to assign a diagnostic hospital to all incident cases. And we developed algorithms epidemiologically to do that. So if you were diagnosed in hospital A, you were assigned to hospital A, and then we looked at how often did hospital A utilize radiotherapy. That's the principle. You can imagine it's not that simple, because some people go to one hospital here, and then they have a biopsy over here, and then they might have their surgery over here. So we had to have rules to assign diagnosing hospitals. And we basically said, it's the institution where you had your surgery, definitive surgery for cancer within a month of your diagnosis. And if you didn't have definitive surgery, it's where you had your original path report. So if you never had definitive surgery for your cancer, it's the center that was responsible for generating the original, not the reviewed path report. And that's basically how we assigned a diagnosing hospital. I'll tell you more about how that went on this slide. So we started with a 2-year cohort. That's about 125,000 cases. We took out people in Northern Ontario. We took out the pediatric population. We took out people with ineligible diagnosing institutions. So that would be a path report from an institution that didn't normally diagnose cancer. So something has gone wrong in the registry system, and this has, unfortunately, not an uncommon event. It's about 0.1% of the total population, but sometimes things get mixed up in the system and the path report doesn't align nicely with where it ought to. We also could not identify a diagnosing hospital in a small percent of patients. But that left 112,000 cases that we could assign a diagnosing hospital to. About 5% of them came from UHN. About 28% of them came from hospitals that had a cancer clinic associated with them. The majority came from other large hospitals and some from small hospitals. So this graph plots the size of a hospital from left to right. So on the left here, these hospitals diagnosed very few cancer cases. These hospitals diagnosed a lot of cancer cases. And on the top here, this is the percentage of hospitals. So this cluster here, this is about only a third of hospitals. These are the hospitals that are not numerous, but they diagnose a lot of cancer cases. So 75 to 80% of cancer patients come from only about a third of hospitals that diagnose cancer patients. So if you target these larger hospitals, you can do a lot to improve accessibility. So these are not counties now, these are hospitals. So we took the hospitals that diagnosed at least 250 cases per year. So these are all large hospitals, that cluster of 1/3 of the larger hospitals. And you can see hospitals behave like counties. If you order them in terms of their utilization of radiotherapy, there are some that way underutilize radiotherapy. There are some that seem to be high. These are hospitals that typically treat breast cancer, and breast cancer skews the utilization rates. But you can see the most hospitals that have cancer centers, the red dots, are clustered together, and it's those hospitals that we use to generate the benchmark rate. So if you look at big hospitals that have RT facilities right on site in the same site, so in Ottawa, for example, we would make a distinction between a hospital with radiotherapy facilities and one without. Likewise here, you can see that those hospitals are responsible for generating the benchmark. And you can do that for all cancers, like this graph shows, or you can do it for breast cancer, prostate cancer, rectal cancer, etc. So Padraig showed you this graph. This is the variation by LIN. These variations in themselves are concerning. LINs are quite big. They have hundreds of thousands of patients. The fact that they vary at all is surprising when you're dealing with that kind of number. But they do vary a fair amount, actually. This is what happens when you standardize those rates. So as Padraig mentioned, we don't just count cases, we adjust them for age and case mix. So much like mortality rates are age standardized, we standardize utilization by age and by case mix. And you can see that the variation goes down a little bit, but it's still substantial. So now I've got the standardized rates on here. There's still some variation between LINs. And the blue dots here are cancer centers that have an RT facility on site. And you can see basically for most LINs, those hospitals outperform the LIN average, as you would expect. Those are the highest performers. So we just look at LIN 1. It's got 4 hospitals that diagnose over 250 cancer patients a year. You can see that the other hospitals are the major reason why the LIN average isn't as high as the best performing hospital. And if you replicate that across the LINs, you get this sort of pattern. So our problem is not that LINs vary. Our problem is that hospitals vary. These are all large diagnosing institutions. So we've got an issue in terms of getting utilization up in the hospitals that are underutilizing radiotherapy. And it becomes pretty clear when you map this out. Here's your LIN, LIN 7. Here are the hospitals. Toronto East General is at the top. Sunnybrook and UHN are the 2 blue ones at the LIN average. And then St. Michael's, Mount Sinai, and St. Joseph are the larger hospitals within the LIN. So I'll ask you to think about these questions. When we did this at the Provincial Radiotherapy Program, I guess in the fall, November, we had clickers and we got people to vote on these sorts of things. But you can think about these. I told you what the dimensions of accessibility were earlier. So you can think about what's the problem here? Why are those hospitals so different? Is it consultation capacity, treatment capacity, distance considerations, travel considerations, affordability considerations, referral or physician attitude, or something else, or none of the above. So we don't know, but this is the opportunity to find out. So if you can diagnose where a problem is, you can start to drill down on the root causes of those problems and try to sort it out. So that's our basic goal. You can ask the same questions for palliative radiotherapy. So our goal is to provide RVPs at every cancer program with these data. I'm going to show you a report that's going to be generated for your LIN. And the idea here is to promote discussion about why these rates differ, to do some drilling down and some root cause analysis about what explains the variation, and then once it's explained, what might improve access to care, understanding better. So Padraig showed you this slide. This is all cancers. LIN 7 is a bit below the provincial benchmark that we set at 33%. Here's how it breaks down for your hospitals. Your entire LIN, that says LIN 7 breast, I'm sorry, I just realized now, that's all cases. So your LIN is a bit below 33. UHN, Sunnybrook, and Toronto East General are within shooting distance. Mount Sinai, St. Michael's, and in particular St. Joe's are all low overall. But what you really want to do is drill down on some detail. So, I'm sorry. This slide shows you that this pattern is pretty typical. Every LIN we look at, we see the same thing. So we prepared a draft report for LIN 13, which is the Sudbury region. And you can see the same thing. The entire LIN is a few percentage points below the benchmark, but hospitals vary quite a bit in terms of how close they come to the benchmark. So this is every LIN has a graph that looks just like this one. If you look at breast cancer, LIN 7 is still low. Now the benchmark is set at 68 because that's the best performing hospitals for breast cancer. And LIN 7 is lower than that. And it's low in most hospitals except Toronto East General. And St. Joe is just touching with the 95% confidence limits, but the point estimate is low as well. So it looks like there are some systematic ways that breast cancer varies across your particular LIN access to breast cancer radiotherapy. For lung cancer, LIN 7 is here. If you look at the hospitals, UHN and Sunnybrook are the high ones. Sinai, East General, St. Michael's, St. Joe's, again on the lower side. And rectal cancer, as Padraig said, this is a bit of a good news story. There's nobody that's there's no LIN, there's no hospital, retract. The provincial performance on rectal cancer is pretty good. But there are some pockets of hospitals that have problems. So this is the initial rates for rectal cancer. And there may be obvious, when you look at this slide, you may think, well, I know Mount Sinai is low, it's because of X. So these figures point out the problem. They don't tell you why the problem is, but it gives you some ammunition to start to think about why the problems might be there. And finally, prostate cancer. This one varies the most among LINs. It's a complex problem. Radiotherapy for prostate cancer, as everybody knows, but the utilization is what it is. And for some reason, it's highest in Toronto East General. You might figure out why, and it's lower in all of your other hospitals. So our goal with this is to provide these descriptive data to all of the RVPs. We presented this concept to the meeting of RVPs that happened a month or two ago. There was great endorsement of this. The RVPs found it engaging and potentially highly useful for their own program development. So although Bill's published this for years, I think with Padraig's help, we're finally on the right track of actually implementing some of this knowledge translation strategy and getting RVPs to take these data into their own backyards and start to think about why these problems exist and what they might be able to do about them to ensure that all cases that ought to get radiotherapy actually get it. So I think I'll turn over to Michelle at this point, and then we'll have general questions after that.
Yeah, I'd just like to introduce Michelle. Michelle's a policy analyst with the Radiation Treatment Program at Cancer Care Ontario and has been doing a lot of work on this.
So there's a lot of information here, and obviously we see there is LIN variation and hospital variation in utilization rates. But what are some of the strategies that we can actually use to intervene with this and try to get our utilization rates up to these benchmarking standards? So I wanted to show you an example. Oh, our slide's a little funny here, but I wanted to show you an example of basically one type of intervention that occurred at Lake Ridge Hospital. So as you're likely aware, as of mid-2005 or before that, there was no radiotherapy facility at Lake Ridge Hospital or in that area. But what happened is, prior to the institution of the radiotherapy facility, there was an outreach program by radiation oncologists at Lake Ridge Hospital where they would go into Lake Ridge Hospital and see new referrals and see new consults, referring them to off-site radiotherapy facilities. So you can see that there is this increase here in radiation utilization rates. And what I wanted to show you is that this increase was not due to the opening of the facility itself. In fact, it was actually done before that with the outreach program. So what this demonstrates is that outreach can be a possible intervention to increase utilization rates at different facilities. And that it really also demonstrates that utilization is an issue and is a topic that's amenable to change and can be successfully intervened with different types of interventions. So another question that we get often is, what percentage of this population for utilization is palliative? Obviously, that would change the approach that we would use in targeting who could increase these rates and how to get these rates up to benchmark standards. So again, this is not a new question. And again, it's Bill McKillop's group out in Queens who did a study published in 2012 for a population-based cohort study, again, 1984 to 2007. And what they did is they analyzed patients, all Ontarians who died of cancer during this period of time, who had brain metastases, and excluded patients with a primary brain cancer. So what they did is they analyzed the proportion of patients who received whole brain radiotherapy. And the variation, similar to what we saw before, occurred with county rates ranging from 1.3 to 8.8%. So again, this big variation occurred. And when they analyzed different factors involved, unsurprisingly, it's younger patients living in communities with a higher socioeconomic status, living closer to a facility with radiotherapy, or being diagnosed with at a facility with radiotherapy on site. And those were the proportion of people who are more likely to receive radiation. So this is a similar graph to what we saw before, here with just the intercounty variation in palliative whole brain radiation therapy. So we see again the darker areas, the black areas are those areas that have higher utilization rates. The white areas are those with lower utilization rates. And again, this intercounty variation is shown. And work is currently being done to use this sort of approach and the same benchmarking approach to determine our palliative utilization rates overall. So what are we doing? So here at CCO, we've sort of been pushing this initiative and trying to see what we could do to increase utilization rates. So we've got three main things that we're working on so far. So as Dr. Brundage mentioned, we're developing LIN-specific reports. We've done a fair bit of outreach to all the different counties to determine what are the types of information that they would like to see within this report that would help them identify successfully the areas that they need to intervene with or the areas that an approach can be used. So we've engaged these regions, we've engaged senior leadership at CCO, and we've gotten a lot of advice onto what the type of information is that we wanted to see. We've done a draft report of this type of LIN variation. And hopefully, within the next short period of time, a couple months, we can develop all of the LIN-specific reports for all those senior administrators to see where this variation actually occurs within their hospital. The second thing that we're thinking of doing is conducting regional roadshows. So to engage regions in identifying improvement opportunities and going out to these centers individually. The key part of this would be to be able to include departments at the table who are not radiation departments. Obviously, it's not a hard sell to get radiation oncology departments to use radiation, but what we want at the table is the palliative, the medical oncology, surgical oncology, primary care, nurses, administrators. Those are the people we want at the table to ensure that everybody has a chance to see where this underutilization exists and where we can actually intervene. And the third thing, as I mentioned, that we're working on, or that Bill McKillop is working on in Queens, is the development of palliative radiation utilization benchmarks. So that data is almost ready at this point, but we're hoping that with this palliative data, we can allow centers to better target areas with underutilization to see if there's mostly a palliative issue or a curative issue in that area. And then the last thing, as Padraig mentioned right at the beginning of this talk, we have an issue with the term utilization. Whenever we say utilization, the first thing that pops to mind is machine capacity and the hours that the machine runs and what's going on there. There's a big problem with this term, and we feel like sometimes the term overtakes the message of what we're trying to demonstrate. So at this point, if anyone has a suggestion for a better term or a better way,
participation.
Yeah, that would be great. So please let us know. So we thought about using accessibility. Again, accessibility, there are some issues with that definition there and what's brought to mind. So if there are any suggestions for a better term than utilization, please let us know.
How do you know it's interpreted that way? I mean, I think of it the way you're thinking of it.
We've actually done, when we've presented this data at various meetings, so we went to our Provincial Leadership Council at CCO and we presented this data, and that's one of the first comments that came out afterwards. It was, well, doesn't utilization mean machine planning? So it was definitely an issue there, and there was definitely consensus at that table that the name needs to change. Yeah. We might have different focuses.
Well, I'll say all of the regional vice presidents that were there, that was one of their major comments. That's the first thing they think about is machines. And actually, in our CSQI, we actually use the term radiation treatment utilization and machine utilization as part of one of the parameters we report.
So definitely something to think about. So any great ideas, let us know.
Is use of different than utilization?
In terms of use of radiation treatment, yeah, that was the title. So definitely something that could be thought about. And with that, that's it. That's our whole thing. So we just want to acknowledge, obviously, the group at Queens who does most of the work, and everybody at CCO.
Thank you. And of course, I have to acknowledge that I didn't actually introduce Dr. McKillop. Sorry. Dr. Brundage, I still see him as my resident here from 1988. Okay. Question. Mary Ann has a question.
So, great data, great presentation, Michael. I have a couple of questions. One is, the cancer registry has changed the way they register cancers, right? They start with registering second and third cancers. So, how will that change? You have, utilization, lifelong utilization. That can mean that several cancers are being treated because many people have more than one. So that's number one. Number two is the 1 year utilization is great for being a surrogate for appropriateness of access to care, but it is not when you plan resources, right? So, and the utilization rates are used to plan resources, right? So sometimes even within CCO, there's a bit of conflict of how you use the information. And the final one is, it's great to have approximate utilizations, but is an important thing is outcomes. Are the outcomes for cancer patients in the places that have a lower utilization different than just utilization?
So 3 great questions. Thank you, Mary. So one at a time. For those of you that don't know, the registry has changed its operation rules. So previously, if I had 10 women with breast cancer, I would have counted 10 cancers. If one of them got a second cancer in the other breast, I would still only count 10 cancers. I would ignore the second one. Now, under the new rules, I have 11 cancers in 10 people. So that's about a 12.5% difference when you account for second cancers and add them to existing cancers. So as Mary rightly points out, that changes your denominator and changes the game a bit. So we've modeled that quite extensively. The first thing we're going to do is analyze everything 2 ways, the old way and the new way, to do a sensitivity analysis to see what the differences are. And we're going to have to come up with translation rules that keep apples compared to apples. It turns out that although that sounds like a big difference, it doesn't actually make a big difference, because it turns out that the utilization for second cancers is not nearly as high as it is for the first cancer in the same patient. So it doesn't have as big an impact as you might think it does. But we have modeled that quite extensively, and we will be correcting for that. The second question about estimating need for capacity. Mary is absolutely right. We have to estimate need for capacity. It turns out that our assumptions for planning that we made a few years ago, based on 10-year projections, are entirely consistent with this one-year utilization of 33%. So you take that new estimate, you translate it into lifetime utilization, you use that to calculate your machines, you account for retreatments in addition to initial treatments. It turns out that we're within a few percentage points of our estimated capacity needs for the next 10 years. That was a fortunate series of events that led to convergence of those estimates when we reanalyzed our data, because those estimates were originally based on the EBRA method, the calculated estimated use. It turns out the benchmarking method predicts a slightly lower utilization estimate over the next 10 years, but that lower estimate is exactly consistent with our planning assumptions. So it turns out our assumptions were correct, even though our estimates were wrong. Is that fair, Mr. Gutierrez, to summarize it that way? So your third question, isn't it just outcomes that matter? Yes, absolutely. As a province, we're extraordinarily bad at systematically measuring outcomes at the provincial level, at the population level. Once we get better at that, and once we measure other outcomes other than just disease outcomes, like patient reported outcomes, and look at the benefits of radiotherapy by measures other than just living or dying, we can have better data that will inform that. But at the moment, we're limited in what data we have at the provincial level to meaningfully compare outcomes as a function of access.
Any other questions? David?
So, thanks, Mike. The McCullough paper, you showed the Australian EBS, the Canadian EBS, and you showed the observation method. I mean, it seems logical that you should go back and redo that table with just your facilities that have the radiotherapy, the expert facilities, so to say.
Yes.
And how does that break up? Is that in the paper?
It's in the paper, yeah. I didn't put it in that table. So the tables are the actual rates.
Yeah.
You're right, David. We should probably put the benchmark rates in that table.
Some of the evidence ones, the benchmark will take closer to I mean, the expert centers, I presume, drive closer to the evidence-based methods.
Yeah, so they're actually synonymous. If you look at the benchmark rates, those are based on our best performance. So it doesn't say that, but that's the information.
The evidence from other diseases, so you talk to economists and epidemiologists, Rifa Katun and others who work with HIV and other infection control, and they basically say that if you have practice guidelines that suggest best practice, real life expectation of utilization will be 80%. If you apply the 80% to the Australian, which are the idealistic expectations of the radiotherapy utilization, apply 80%, then you get our benchmark rate. So it's entirely consistent with the fact that nobody in the whole wide world ever has 100% compliance with idealistic guidelines, because there are other factors. There's distance, patient preferences, stigma, physician buying, whatever. So the people who plan resources usually apparently plan to 80% because they think that that's consistent with real life. So this whole conflict between the very idealistic Australian and more pragmatic Canadian can be explained by 80%.
So we discount the Australian estimates by 80%, get the Canadian estimates. At large numbers, that works fairly well. If you look at the detail on some of those decision trees, particularly prostate cancer, they don't factor in active surveillance, for instance, at all. It's invisible. So the fact that we're not treating a whole whack of prostate cancer patients now with any treatment is invisible in that method. And those are the sorts of things we worry about from a methods piece. So yes, you're right. At a crude level, you can probably get close. But
benchmark rate is easier.
Well, benchmark rate accounts for all of those things explicitly, right? So instead of discounting something by a hypothetical 80% because of preferences or non-perfect world, why not just measure it and then all those assumptions go away? You don't have to make any.
Well, I don't want to monopolize the conversation, except that your assumptions for benchmark rate are quite idealistic too. I mean, there are very, very few places where there's no sort of interest in treating more people. You know, you say there's no benefit from sort of.
There's no incentive.
There's no incentive. There are very few places in the world, whichever way you make it, where there are no incentives. There are no incentives if you don't have empty equivalences.
Yeah, you're right. It's hypothetical that we could have some incentivization of radiotherapy treatments, but at the provincial level, if you've got 5 hospitals at very different parts of the province, all hitting about the same rate, it's a reasonable assumption that that's a good rate to target, I think. It would be hard to argue that all 5 hospitals are 5% systematically overutilizing radiotherapy. You could have that debate, but I think it's a pretty tough case to make. Thank you.